Good evening, everybody, to this Australian Medico-Legal College webinar on causation of chronic low back pain, a medico-legal perspective. It's been the elephant in the room for decades, and it's obviously a thorny and relevant topic because we have a large number of acceptances for tonight's webinar. So it should be a very interesting topic. However, we anticipate that by the end of this session, as independent medical examiners, we'll all be able to provide more clear, decisive, well-supported, evidence-based advice regarding causation of low back pain. It's such a large topic, so we won't be digressing into treatment or permanent impairment or work capacity, etc. We'll just be sticking with causation in regard to chronic low back pain. Many papers have been written on causation in regard to acute low back pain, but there's unfortunately precious little in the literature to give us guidelines in how to address causation of chronic low back pain, specifically in IME reports, which is going to be the topic for today. We're very fortunate tonight to have three panelists, each of whom have specific, unique expertise in these various concepts of causation, IME work, chronic low back pain, joining all that together. Dr. Vinny Khurana is a Sydney University and Mayo Clinic trained neurosurgeon based in Sydney. He holds 2 scientific research degrees, including a PhD from the Mayo Graduate School. He has 2 US patents, and Vinny enjoys medico-legal consulting, spinal reconstruction, and medical publishing. In fact, he specifically published a paper on today's topic, which is causation in spine-related medico-legal matters. Very relevant paper in regard to tonight's discussion. Professor Ian Harris is an orthopedic surgeon and academic based in Sydney. His research is centred on testing the effectiveness of surgical interventions, and we're fortunate to have the benefit of his research expertise. Dr. Ian Dickinson is a Brisbane orthopedic surgeon. He's been in private and public hospital practice and served on both the Royal Australian College of Surgeons Council and the Australian Orthopaedic Association Board. He's a past deputy chair of the Queensland QComp, Workers' Compensation Panels, and was on the committee of the Queensland Medico-Legal Society. He's published in the areas of surgical standards and orthopaedic oncology. Ian Dickinson currently has a medico-legal practice in both Brisbane and Melbourne. Now, Australian Medico-Legal College is also very fortunate to again have, as tonight's facilitator, Sue Larson, co-founder of MEDirect. Sue is a Sydney University graduate and entrepreneur who has co-developed MEDirect, which is Australia's first medico-legal practice management system, enabling medico-legal experts to work directly with their referrers through a custom-built technology platform. The purpose and key topics for tonight's webinar will be distinguishing between causation of non-specific low back pain and causation of defined lumbosacral diagnoses, discussing the frequency of chronic low back pain where there's been no trauma or strenuous activity, reviewing the relevance of MRI and other scan abnormalities in asymptomatic individuals, emphasising the importance of pre-injury history, emphasising the importance of the details of the claimed trauma from this specific claimant, highlighting the use of evidence-based research in assessing causation in chronic low back pain, and ultimately offering practical advice in how to conduct effective causation assessments in our IME reports. So I'm really looking forward to hear what our panelists have to offer, and over to you, Sue. Thank you.
Well, thanks, Richard, and welcome everybody. We're going to start tonight's discussion by firstly looking at the distinctions between non-specific low back pain and defined lumbosacral diagnoses. And secondly, how various imaging modalities can inform our understanding of chronic low back pain. Dr. Khurana, could you share your insights on these aspects, please?
Sure, Sue, and thank you to you and to Dr. Seckel for the introduction and to the co-panelists for their presence and insight. So, look, I suppose the first thing to do when thinking about low back pain and putting it into the categories of non-specific versus specific is to actually define what those entities might be. And I see that you've talked about defined lumbosacral diagnoses. So we can probably think of that more as a specific low back pain. So non-specific low back pain is really a diagnosis of exclusion in some regards, because it is a symptom, low back pain, that does not have a defined or known pathological or physiological basis. And so that's then categorized as non-specific. Whereas specific low back pain is something where there is known pathology or pathophysiology, and so it is more disease kind of oriented, so that where we have the defined lumbosacral diagnoses, that would fit more with the concept of a specific low back pain. Now, non-specific low back pain accounts for about 90% of low back pain, and that is without known or recognized etiology, whereas 10%, ballpark 10%, accounts for specific low back pain. And in specific low back pain, we're going to be thinking about things like, a fracture, a substantial disc herniation or spinal stenosis, infection, neoplasia, and even visceral problems that don't affect the spine, but somehow present as low back pain. So the importance from a medico-legal perspective is that there's a new dimension, because what we see, especially in IMEs involving spine, is not all comers from the community, but a subset of referred individuals who are claiming their low back pain is somehow related to occupational duties or occupational trauma. So in that situation, there's an added dimension of figuring out what is the diagnosis and how the diagnosis then relates to the occupation. And is it really organic, or is there a non-organic component to it? Now, Sue, if you're able to bring up my first image, please. So this study was published several years ago. It's 2015 in the American Journal of Neuroradiology. The principal group was from Mayo Clinic, but it was a multi-center study. They looked at the literature of involving asymptomatic individuals, so no symptoms, and they wanted to characterize their spinal radiology. And there were stringent inclusion and exclusion criteria. I looked through the methods, and it looks like a very sound paper. It has been quoted extensively and does give us a lot of good insights. But essentially, they've narrowed their field down to 33 studies worldwide, all in the English peer-reviewed literature, and over 3,000 persons involved in those. And what they found was that you can see I've put linear where they're linear, and there's steep linear associations, shallow linear, and then there's parabolic associations. And what this is by decades. So along the x-axis here, this is the different colors are decades, and the different groups here are, for example, disc degeneration, disc signal loss, disc height loss, disc bulge, disc protrusion, annular fissures, and the last two, which are parabolic, facet degeneration and spondylolisthesis. But the take-home message here is that as each decade passes, there's actually quite a substantial number of people with radiologically definable pathology, but no symptoms. And so the take-home message here is that just because you see something on a scan doesn't mean that person is symptomatic, and that pathology is causative even in persons who are symptomatic, because we know there are pathologies like that may be entirely asymptomatic. So I suppose the question then becomes, for us as medico-legal specialists opining on spinal matters, is how you then sift through what is causation due to in this particular matter. Sue, may I have the next slide? So from an organic perspective, that is something that might have a definable cause. This is a busy set of images, but essentially the message here is that there are lots of structures that can define and generate pain, and they're not just confined to the spine. As I mentioned, some organic conditions, some specific low back pain conditions actually originate away from the spine, but are felt as referred pain in the spine, particularly intra-abdominal and pelvic pathologies. But essentially, if we're talking about spinal pathologies, there are so many different structures that constitute the spinal anatomy. One has to look at those carefully, particularly from a radiological perspective, but also with neurological and historical correlates to try to identify which of those may be symptomatic in terms of what patterns fit. So it's not just the presence of low back pain and neurological symptoms, but then correlating it. And I know some of the panelists, my co-panelists, will be discussing that in further detail, so I won't go into it. But I just wanted to also let you know in the bottom right quadrant of this, there's the diagram of kind of the pathways which subserve pain. And the only reason I included that was not to forget that pain does have learned components as well, and the concept of central sensitization, where there's a thought of its physiological role in pain, may also have a component of learned pain behavior. So when we talk about pain, it's not just the structural aspects of it, but also physiological and potentially non-physiological, non-organic aspects, such as what Elle had raised many years ago. Sue, may I have the next slide first? So when we talk about low back pain, it is not just pain in the back that we're talking about, and specific versus non-specific, but essentially what we're trying to identify in the medico-legal practice is what is the cause of it. And the causation of it is something I've published on, others will speak on and perhaps have published on as well. But this diagram is just to remind us that there are neurological symptoms that are associated with low back pain, and for us to keep in mind whether or not those symptoms and the signs that accompany those symptoms, whether they correlate with one another and whether they follow the kind of well recognized and I think accepted dermatomal and myotomal patterns. And that's kind of part of a rigorous examination, does keep that in mind, looking for such consistencies and inconsistencies. And Sue, I have the next slide, I think, which is perhaps the last slide of this part of the segment. But I wanted to show you that when we look at investigations, and I rely heavily, not exclusively, but heavily upon them, I review investigations myself, obviously, because for a practicing neurosurgeon reconstructing spines, I can't rely on reports. I have to see what the radiological pathology and anatomy are, and I have to know it very well. And so when I do my reports, I actually meticulously review all the available imaging. I search all the various PACSs that I can, and I find the radiology. And what I like to see particularly is multimodal imaging wherever it's possible, wherever it's available. And if it hasn't been done, I often order it. And what I mean by this is, now we're used to things like plain X-ray. So the bottom right, you'll see there's a plain X-ray, but the standard X-rays and standard CT and standard MRI studies that we do are all in static positions. With CT and MRI, the positions are supine and non-mobile, unless we order dynamic imaging. So we get structural information from the static types of X-rays of CT. Top right shows, for example, spondylolisthesis coming from a pars defect, an isthmic defect in the facet or the pars region of the facet joints, leading to a slip. The bottom panel in the middle shows an MRI with a red dash circle showing modic changes along a degenerative disc space with a small herniation at the back. And these are static studies. The bottom right, it looks like a static study, but it's actually part of a dynamic study where the patient was asked to forward flex and extend to see if anything changed between the relationships of the bones, which it did in this particular patient during flexion versus extension. And what I've shown in the bottom right with those little purple lines and the arrows is spondylolisthesis becoming exaggerated in flexion. I haven't shown the extension view, but it was reduced in extension. So there's a good example of a dynamic study that helps. Now the top two panels on the left and the bottom left panel are examples of physiological studies. Here we're looking at blood flow to various regions of the spine in this case, where blood flow is abnormal and lights up like a Christmas tree. And that's a nuclear medicine study, SPECT, which can be done in various regions to provide a physiological correlate, i.e. what's angry, what's not, compared with the static studies, which may not show something specific. So in a person who has multiple levels of pathology, one of them may light up like a Christmas tree, or one or more tissue structures may, and that gives you some idea of disease activity when they're presenting, and therefore a better idea of what may be causative of the symptomatology. And then finally, in the very bottom with the little inset with the outstretched hand there is just a reminder that electrophysiology, such as myography and nerve conduction studies, are very important on occasions in order to determine whether something actually is present and how bad it might be in terms of motor and sensory conduction and muscle contractility as part of the neuromuscular complex. And one last thing to mention about imaging is, as far as this imaging is concerned, is that there is also dynamic MRI available. So upright multi-positional MRI allows you to flex and extend and have the patient seated upright to see what happens to these tissues when they move in different places. So when we look at these static scans, it's not the complete picture. Finally, just two quick examples. Sue, am I on time? So
You're
two,
fine. Yep.
two quick examples of things that are important that I recurrently see. I told you that I don't rely on imaging reports. I find them valuable, but I often find that from my particular perspective, looking at them, sometimes things are missed or underreported, and sometimes serial scans are not compared, even when they're available to a radiologist on the same PACS. And it's that serial imaging, for example, pre-injury, if you discover those versus post-injury, when I look at, and I actually reproduce images with annotations such as what you see here and describe them as part of my imaging analysis to show to a layperson even what I'm referring to when I talk about pathology and changes in pathology. And two quick examples. Recently, I saw two patients in the last week with these particular entities of relevance to this talk. One was where the radiologist had commented on pathology at a particular level, but had not commented on the change in pathology at the level above, which was evident when you compare the two scans. So when the operation had been done at the level below and the change had actually happened at the level above, the conclusion was no evidence for the patient's symptoms is found here, something along those lines. Whereas when you find the study from some months earlier, you can actually see that something has changed between those studies, and that may well be accounting for it when you look at the big picture of how that patient presented. The second example was a person, a young person who had a disc replacement surgery and was still having really substantial symptoms from it. The disc replacement looked anatomically perfect to me, even on physiological studies, dynamic studies, and static studies. I thought it was an excellent result from another surgeon. She had presented to me for a second opinion. She was considering having further surgery for little pathologies that were there, which were thought to be contributory to her symptoms, but they were extreme symptoms. They didn't match my observations, passive observations, and she was asking for surgery. But at the very end of a string of consultations and some additional testing, I actually put it to her and a mum, who were both present at the same time, was, could there be a psychological cause for this? Could there be some other thing? And they actually at that moment looked at each other and then requested review by a psychologist, which I've now made as part of a referral. And I just wanted to let you know that as a clinician, I deal with this, obviously, because I don't want to take a patient to surgery when they're not suitable surgical candidates, particularly if there's a psychological aspect to the presenting pathology. But as a medico-legal neurosurgical specialist, I deal with this a lot. And I'll come to some of that in the later part of my presentation. So thank you.
Thank you, Dr. Khurana. I appreciate your insights on this. I'd just like to, for the next 5 minutes, just open the discussion to our other panelists and invite them both to share their perspectives on a couple of really important questions. Firstly, Dr. Dickinson, could you share your approach to causation in cases where there is no clear pathoanatomical cause and yet there's multiple contributing factors at play?
Yes, I think where there's a potentially multifactorial situation, it's really important to avoid all of the issues of imaging whatsoever, and to take a good history and to try to find out what it is that's causing the patient's problem. You've got to remember that very often in the medico-legal cases, we're seeing people at least a year after their incident, sometimes much longer, depending on the jurisdiction, and they may have a poor memory of what's happened, and it may not match up at all with any of what Vinny's been talking about. So that would be my short answer at this stage of this seminar.
Okay, thank you, Dr. Dickinson. Professor Harris, I'd love to hear your thoughts on the relevance of imaging abnormalities in asymptomatic individuals.
It's just gives us a background. So knowing what Vinny has pointed out there in one of his first slides, the very high incidence of imaging abnormalities in asymptomatic people and the very poor correlation between the presence of what are mainly considered degenerative findings, but these findings that increase with age, which he pointed out, there's a very poor correlation between these and the presence of pain. So we have to avoid jumping to the conclusion that a lot of people do. I mean, patients do it and surgeons do it, is they see something on the scan and they see a patient with pain and they immediately think that those two must be causing each other. And I think that's a trap that we fall for all the time, and it's not necessarily valid. And it's the same thing with I'll talk about it later probably, but the history of an incident or an injury, and just because the patient felt pain and they happened to do something a few days earlier, it doesn't necessarily mean that the thing that they did a few days earlier caused the pain. And so I think it's just a good thing to point out very early here that association is not causation, because this whole webinar is about causation. And I think that the high incidence of abnormalities in asymptomatic individuals is just really just pointing that out.
Absolutely. So now is a good time to start to look at the evidence surrounding causation of lower back pain. And Professor Harris, your expertise here will be invaluable. So I'd like to shift the conversation a little bit now. I'd like to start then with a discussion on the occupational risk factors for firstly non-specific low back pain, and secondly for intervertebral disc protrusions. What is the research in these areas, Professor Harris?
Did you want me to go on to my presentation? Yeah. So I'll share the screen.
Absolutely.
Yeah, because I've got some slides I'll show.
Great.
Hopefully it won't take too long. So you can see that okay? Just a single slide?
Yes, we can.
All right. And these are, I'm going to go through the evidence a little bit, but also contribute to my observations when I have to do these sorts of medical examinations as well. And one thing I like to clarify is this difference between a specific incident and chronic occupational exposure. And I think the former, the specific incident, is probably the most common one. It's normally something happened on a specific date that has been blamed for the chronic low back pain or symptoms. But sometimes it's also to do with not a specific incident, but chronic occupational exposure. So I'm going to approach both of those. And we're going to talk about specific incidents first. My approach to causation is look at the likelihood of the incident causing the current image findings. And I'll go back. And to do that, you've got to look at the likelihood of these imaging findings occurring without that incident having occurred, and look for other explanations for those imaging findings. But that's the imaging findings. You've also got to look at the likelihood of the incident causing the current symptoms. So to do that, when you're looking at causation, there's a thing called the counterfactual. You have to look at what would have happened if that causing thing wasn't there. And so you look at the likelihood of those findings causing the current symptoms. So would those symptoms have occurred anyway without the incident, and look for other explanations of the current symptoms. So Vinny's already covered this, so I won't go through it again, but these are the sorts of percentages that you see in different age groups. They're very high, and these are people without symptoms. So when you're looking at imaging, you do have to look at the timing of the incident. And you should be able to detect recent trauma. So if you have an MRI scan normally, but if you have an imaging study that's taken soon after the trauma, if it has been a significant traumatic event and there has been some damage caused, you should be able to see that evidence of recent trauma, not degenerative changes, which more likely than not predated the incident. So if you see significant degenerative changes in an MRI scan a week after the incident, that incident didn't cause them. So you're looking for actual trauma, not degenerative changes. And look at the mechanism of the incident. And sometimes you really have to dig deep here a little bit. It's often the history of the incident varies a little bit between reports, but I have found more often than not, when you really inquire, it's not much of a physical trauma. You know, they'll say that they collapsed, and when you say, well, did you fall to the ground? Well, no, I caught myself. So, you know, you're getting an idea of the degree of trauma that's gone into it. And when you're looking at specific incidents like an acute disc herniation, there's a book which is very helpful, which Richard Seckel pointed out to me a short time ago, which is an AMA guide to causation. And they've reviewed the evidence for lots of different causes in all the different fields. And they concluded there's insufficient evidence to attribute a disc herniation to minor trauma or to ergonomic factors. So that's imaging. And what are the other explanations of the imaging findings? Well, you've seen from Vinny that age is one thing that predicts imaging findings. Genetics is another thing that predicts it. And of course, previous injuries or other intercurrent injuries may also explain it. And there's not very good correlation between imaging findings and symptoms anyway. We tend to rely a lot on the imaging, but the imaging doesn't necessarily mean much. So when you're looking at degenerative changes, not acute injuries, but degenerative changes, in this particular cohort study from Japan, they followed patients for 10 years and found no correlation with MRI findings and low back pain over 10 years. For this particular study, there was no correlation between degenerative changes, and neurogenic pain. And in this larger cohort study where people were followed for 6 years, a large number of people found that progression in degenerative findings or degenerative findings were not associated with clinically important changes in back pain over a 6-year period. So just because you see something like those things that we listed, it doesn't mean that they're causing the symptoms. So what is the likelihood then of the incident causing the current symptoms? Well, often with the incident, a specific incident, I've found that there's often no evidence of specific trauma, or if anything, there may be some, muscle pain or something around the time of the incident, but there's no evidence of specific trauma either on physical examination or on scans done soon after the trauma. And quite often, and this is why you need to take a history of it, there's often a disconnect between the incident and the onset of symptoms. And so, for example, they say they were lifting something or doing a particular exercise or doing some particular heavy work, and then the next day, or when they were driving home, or some other time, there's a gap where they didn't have symptoms and then developed them later. It doesn't really fit with the physiology that we know, that you could have an injury and then sometime later feel pain from it. And also an acute injury, whether that be muscular or tendinous, or perhaps something that we can't detect on an MRI scan. If there is an acute, perhaps soft tissue injury to the spine, it does not explain chronic worsening symptoms. If you have an injury to your knee or to your shoulder, if you tear something, or you rupture your cruciate ligament, or sprain your ankle, it will be very painful, and that pain will decrease over time. It doesn't make sense that the pain would gradually increase over many months, or in many cases that I see, over many years. And so these don't fit with a specific traumatic incident, which is what we're often asked to make judgment on. And you have to look for other explanations of their current symptoms. And often people have a heightened awareness of general back pain that everybody has anyway, but they just pay more attention to it now, and they get very sensitized, and they're vigilant and alert to any back symptoms. And often it's associated with psychological factors such as yellow flags, which I'll discuss later. And these are some of the predictors of chronic pain, and these are the strongest predictors of chronic non-specific low back pain. And some other interesting research, one particular twin study looking at exposure and imaging findings, found that genetics was the strongest predictor of imaging findings of degeneration in the lumbar spine, and unrelated to physical exposures, even when twins were doing completely different types of work. Some doing heavy work, some doing light work. Chronic work exposure and symptoms. So now I'm moving away from the specific incident of I twisted my back on Tuesday and then developed my symptoms. Now we're saying it was 20 years working as a fireman or a manual handler in a warehouse that caused my symptoms. The AMA causation guides conclude that there's insufficient evidence for any physical factor predicting chronic low back pain, such as heavy work, bending, twisting, awkward postures, and a lot of things that we hear about. And unfortunately, these sorts of things have fallen into common mythology, and in society, people, to them, it just makes sense that heavy work would increase your chance of back pain, whereas many studies have shown that this isn't the case. And there's been some fascinating studies done over the years where they've looked at employees in large organizations where they're doing, the managers, secretaries, heavy laborers, light laborers, part-time, full-time, and they've come up with things such as the strongest predictor for reporting an episode of back pain is job satisfaction. It's not related to the amount of work you do. But sometimes you hear reports of more complaints of back pain in manual handling, but when you look at the evidence, the association really isn't there, and quite often people perhaps expect to have back pain, or they're more likely to have back pain diagnosed or other conditions diagnosed. The other thing that doesn't fit when you look at the evidence, if manual handling and the way we lift and bending over and picking things up and twisting were a problem, then you would expect the resultant back pain to decrease if we removed those causes. And there's been a lot of research done on manual handling techniques and correcting people and lifting with your knees and not your back, and wearing belts and all these other things, and educating people on manual handling techniques. But all of those studies have been reviewed. There was, in fact, this is a few years old now, but there was a lovely Cochrane review which looked at all of this. And a lot of Cochrane reviews end up concluding that we don't really know one way or the other. But this Cochrane review actually concluded that there is moderate evidence that manual material handling advice and training does not prevent back pain or back pain-related disability when compared to no intervention. So these things don't work. And the reason why educating people on how to handle materials doesn't reduce back pain is because handling the materials in the first place didn't cause the back pain. That's the most likely explanation. So what are the other explanations when you have someone with chronic back pain? Age? Well, no. We've seen that age is associated with degenerative changes, but it's not necessarily associated with chronic low back pain. Obesity, again, it's something, kind of makes sense, but there's not a strong link. Some people say smoking, again, not a strong link. A history of back pain is a predictor of back pain. And the yellow flags and compensation process are associated with chronic low back pain. And for those yellow flags, there's certain screening tools that you can use. But basically, you're looking at people who avoid activity because they're this is fear avoidance activity. They're fearful of worsening their condition. They often have generalized widespread pain. They often have features of pain catastrophizing. It's the worst pain ever. It's terrible. It's getting worse. I can't walk. I can't move. I can't sleep. And they often have a desire for a simple technical cure that should be. And they often have altered mood as well, and will describe frustration, anxiety, loss of sleep. So these are the flags for chronic pain. These are the things that best predict chronic pain, not the presence of things on MRI, not how much hard work they did over the last 20 years, or whether they turned awkwardly on a certain day of the year. And this is the problems we have where we see people exposed to something, whether that's a workplace incident, or they fell down the stairs, or they twisted their back while carrying a box. And we see them with pain. And as human beings, we jump to this causal conclusion, but that's not how causation works. And this is a logical fallacy in Latin, post hoc ergo propter hoc, which means it follows, therefore it is because of. And this is a fallacy that we often fall for. We see two things associated with each other. You did some heavy work 2 weeks ago, and now you have terrible pain. Therefore, the terrible pain was caused by that particular episode at work. And that's usually not the case. And so you need to compare to the counterfactual. What is the probability that those imaging findings would be there? What is the probability that this patient would complain of back pain without the exposure? And I see so many examples of patients who are in toxic workplace environments where they've had, perhaps difficulties with their supervisor or superior or a co-worker, and it's gotten to HR problems and even legal problems where they can't work with this co-worker. They're very distressed. They're anxious about going to work. They fear going to work. They hate it. There's clearly psychological problems going. And then one day they'll just slip a little bit on the floor, and they'll complain of all-encompassing back pain from that point on. And clearly this is a yellow flag, and the minor physical trauma is not the cause. And it's likely that any other thing would have triggered similar results. So just in summary, in imaging studies, degenerative changes are common and not strongly linked to low back pain. Disc herniation is not linked to postural minor trauma. And a specific acute incidence, look at the mechanism and the timing. The pain should occur at the same time, not sometime later, and the pain should decrease over time, not increase. And is there actually any evidence, physical evidence of trauma to the spine? And for chronic exposure, it is basically not linked to work activities, but it is strongly linked to other factors that I've grouped under yellow flags. So I'll stop there, thanks.
Thank you, Professor Harris. What an amazing summary of the evidence, and it's fantastic to hear you discuss those, because it's quite difficult to make sense of the evidence that's out there. As you say, there's a lot of conflicting views and mythology that's become an accepted approach. So it's fantastic to hear the evidence. So thank you for that. I wanted just to now invite our panelists to share their perspectives on translating this medical evidence into medico-legal determinations on causation. And start, Dr. Khurana, with you. You've done over 2,000 medico-legal assessments in your brief years. What challenges have you experienced in translating the medical research findings into medico-legal determinations, and how have you gone about managing this?
Okay, so Sue, would you be good enough to put up the 6th slide, which was that flow chart? So I think it's a busy slide, but I think it's kind of relevant. And I apologize for the busyness. It's really to help me, but I just want you to know the leftmost box is box 1, the next one is box 2, and then the diagnosis box is box 3. But I just wanted you to. So the challenge here is that. If you look at metadata, like everything we digest, everything that Professor Harris has just told us about, everything that I spoke about at the beginning, it's all metadata. And the reliance upon any one of those things is a fallacy. And so the approach here to try to sort out causation where we have literature that might say one thing, a history that might be one thing, a set of investigations may be another. But the real key is, in a medico-legal setting, a forensic approach. And that really means it has to be scientific. So it's got to be comprehensive, it's got to be impartial, and it's got to be analytical and systematic. So as some of the speakers have said, I think Dr. Dickinson, really we have to have a history that's meticulous, and it has to not just focus on just the prima facie aspects, but really has to dig deep, has to look properly into past history, has to look into the symptoms, and also compare histories between what I was told versus what Professor Harris was told, or Dr. Dickinson was told, or A, B, and C. To see if there's consistency. An examination, the same thing. It has to be forensic. It has to start with a set of observations that are passive, that you are making as you're even taking the history, to see the facial expressions, the number of positional changes, eye contact, body language, you name it, and then the examination itself for the objective signs, whether there are signs that you would expect to correlate with what's being reported, or whether there are clinical inconsistencies. And I think this was all brought about by, I think, Waddell, and there's been criticism and validation of all of that. But the bottom line is that it's true, I believe, that not everything is organic. So examination is really important. Investigations I've already spoken about, meticulous, not just looking at the studies themselves, but comparisons of studies, wherever that's possible. Documents, so there's documentary evidence. And as I think has been touched upon, we often see somebody not a week after trauma or a day after trauma. Sometimes it's 20 years after the alleged incident. Sometimes it's obviously less than that. But what is really important to me is that I have a forensic analysis of at least a good solid body of documents. And what I like the most is the serial documentation from GPs and allied health professionals in real time, not what another specialist might have opined as causation and have taken a history 10 years later, 6 months later, or a year, but what was actually being reported in real time. And then when we look at documents, what is the correlation between people who have been delivered that history? And then we come to the literature. You really, I think it behooves us to be very familiar with the literature. Some of the important studies have been touched upon today, but I think in particular, I think there has to be a knowledge, it would be incomplete without it, of the kind of biopsychosocial paradigm, not just the biological scientific studies like radiology that we talked about earlier, in asymptomatic individuals, but also studies of the compensation litigation environment, because this is, as I think Professor Harris has clearly articulated as the part of the yellow flag concept, clearly there is the presence of that aspect. It's not to say that it is the overriding presence, but it is present. And one has to try to distinguish with knowledge of that literature as well, how it might play upon settings such as IMEs. And then training and experience, your own. It's anecdotal, I suppose, to some extent, but it is part of the mix. And so if a rigorous scientific method's applied, no matter what the literature might say, or a document might say, or an investigation might show, or a history might reveal, whatever it is, it's a meticulous, comprehensive approach that brings all of that together in the setting of your own expertise to come to, as best as possible, a diagnosis, and then apportion the diagnosis. And I will just briefly mention before I finish up here, the apportionment. Sue, could I have that last slide? So I have published, it's based on 20 years of operating, and 15 years, not a lot, but 15 years of medico-legal consulting while I'm operating. And I've published this article, which was just my perspective on how I approach apportioning etiology. Now, they only allowed me a handful of references. There were so many more, but there is a table in that, and it's downloadable, and I will provide it to both Sue's group and to the college for free download, in case it should be of any interest and relevance. But how I apportion etiology, the methodology of that is spelled out there in detail, and I won't repeat it. The only other thing to let you know is currently in peer review. It's been through pre-submission peer review. It's now in international peer review. It's just an article that I have written that really does kind of correlate well with today's discussion. And when that is available, I hope it's published in about a month. I will put that up. I think you'll find that extremely relevant to everything that we've talked about today in terms of specific, non-specific low back pain and forensic approach to it. So that's all I have to say. Thank you.
Thank you, Dr. Khurana. Now, the discussion so far has talked a lot about forensic skills. It's talked a lot about meticulous history taking and investigations. And so we thought it would be valuable to learn how a very experienced medico-legal assessor approaches the evidence, what they look at, and how they approach the key sources of information to be reviewed when they're going about assessing causation, and also what role the history plays in the determination. Dr. Dickinson, you've been a medico-legal assessor for many years, and your real-world experience is very important here, and we'd love to learn about that. What kind of key sources of information do you review? What weight do you put on it, and where does the examiner's history fit in?
Well, thank you, Sue. We've heard a lot from both Ian and Vinny, And what I would say is that whoever is practicing in these East Coast states of Australia needs to know about this book, which I don't think appears on your screen. Don't know if it does.
Bit closer, go a little bit closer, and it should show up in
Yeah.
front of. No,
No, nothing.
nope.
Yeah. Anyway, it's the screen seems to be too clever. It's the AMA Guide's 5th edition, and I think anyone who's doing legal practice on the East Coast states needs to know about the 5th edition completely thoroughly, and they need to read it, even if they're doing an AMA 4 assessment, as they do in some of the jurisdictions, and they also need to read it completely, even if they're have Chapter 18 excluded, as they do in some of the jurisdictions, I think particularly in New South Wales. And the reason for that is there's some pearls of clinical information in there, as well as just rules as to how to do an impairment assessment. So I think that's really important. I do think that the guides that Ian and Vinny have both mentioned, the guides to causation, are really helpful. It's a somewhat dense document, but when you go look, there it is.
Thanks, Richard.
I think that one's held up much better than mine could do. So I've stopped trying, but so well done. So I think that's really important to have as a guide, because you can specifically get information about these specific things, as has been mentioned. We did talk, there's been quite a lot of talk already about the importance of the history. Looking at the contemporaneous doctor's notes are really critically important, and the contemporaneous history is important. Did they get out of the car and run around and try to save everybody else's lives, and then suddenly complain of back pain, as Ian Harris has suggested, 3 months later, when it was well and truly post hoc? And I do agree with Ian that post hoc fallacy is exactly where a lot of medicine is, and we have to be very careful of just assuming because something follows it has been caused by. So the history is critical, and the review of the contemporaneous notes. I think it's very interesting to me to see in reviewing clinical examinations that patients don't take the history, or they only look at the x-rays, and that they come to a conclusion based on the x-rays when the x-rays have no relevance at all. And we've heard a lot about that. I am very mindful of the fact that what happens with injuries is that the natural history is that they resolve. Whatever happens, if you break a tree, a sapling, it will heal itself and continue to grow. If you damage your skin, it will heal. If you hit your thumb with a hammer, it will hurt like crazy right at the beginning. It hurts immediately with all of those humoral factors, and then it gets better with time, and then you don't even know that the hammer was there. So I think that's often forgotten. And so the actual history of the complaint related to the event is very important. As Ian has said, the relationships between chronic events are extremely tenuous, and the unhappy patient who's unhappy for all sorts of reasons is can really throw one off the scent. And for that reason, I try very hard to interview people by themselves. Sometimes they come in with a support person, but if they come in with a support person who happens to be their spouse with whom they're fighting, then I think that and you're likely to get a very slanted view, and it won't be very helpful. So I'm very aware of that. I think everybody should be aware of aspects of illness behavior. My belief is that illness behavior is often doctor and physiotherapy induced behavior. If you, as a not necessarily very well educated labouring person, perhaps not with English as the first language, and you're unlucky enough in life to have drawn those straws, and then you go along to people who you would consider to be extremely bright and very well educated, and they confuse you with science, either from a surgical opinion, or worst of all, from a surgical therapy, or from needles from a pain specialist, or numerous manipulations from a physiotherapist over a year or two, then it's not unreasonable that you would be very disappointed that you hadn't got better. Your expectations would be that you would get better. And my observation is that the encouragement of continued participation in the medical system is completely counterproductive. One should decide on what the treatment is, and then the treatment should very well in back pain be as little as possible, and with some sort of homeopathic therapy, but for a limited period of time. And the patient who says to you, "Oh, well, I've been going to the physiotherapist for a year, and then I still haven't got better," and I say to them, "So why are you still going?" And they say, "The physiotherapist told me that I would get better, it would be helpful for me." Then you know for whom that treatment is going to be helpful, and it's not the patient. So there are multiple factors that are not very scientific, but are useful observations. The other aspect of all this is that patients become very immune to the litigation system. Once they're in the workers' compensation litigation system or third-party litigation system, they are really victims of the system. And it was very well shown in my teaching group and peer group that the worst operation you could do on anybody was to do a cervical fusion on a patient with a work cover claim. The failure rate in that group was 100%. More recently, that's been shown in shoulder surgery. I'm not sure what the numbers are in back surgery, but I suspect, and I'm pretty sure that Ian Harris has the information that the outcomes are pretty poor. So, you know, the patients do very badly with these sorts of interventions. And I think that you, as a medico-legal practitioner, can guide your referring legal practice to these outcomes. It was raised before, I can't remember by whom, that you know, sometimes the information that's been given already about the relationship between the radiological information and the clinical behavior is not very well understood. I think it's very well understood by the legal practitioners that refer me work, and they simply want me to confirm their suspicions that there is no relationship. And certainly, very often they ask questions about, well, could this disc protrusion have been caused before the event, or quite commonly now, after the event, by some sort of major trauma that has appeared on social media and that has been tracked down. So, so there's quite a lot of wily investigation going on by the lawyers, even before the doctor gets to see the patient, and so the doctor is really there to corroborate what the lawyer is already considering is the fact. Those legal practitioners who practice within this area become very knowledgeable by reading all the same stuff that either we are reading or that we should have read. So I want to guide you to a couple of things. I think it's very important, regardless of whether you think I'm too loyal to the AMA Guides 5th edition, you should certainly read chapters 1 and 2. And particularly now that the subject has been on causation, you should read at least section 1.6a, page 11 on causation, because it does actually guide you as to how to use the rest of the guides. Page 19, 2.5c on consistency is really important. And that's particularly important where sometimes, particularly in the New South Wales jurisdictions, you're guided away from making sensible decisions about how you will assess impairment. And then the other thing, of course, the catch-all is section 1.5, page 11, which is incorporating science and clinical judgment. And so that allows you to use quite a breadth. And I always try to remember that the guides are titled, the first word in the title of the book is Guides to Assessment, and they are not meant to replace clinical judgment. I think that the key to a satisfactory outcome in medico-legal reporting is knowing your subject, that is the subject of back pain in this circumstance. And there are plenty of good references. I have one here which I can't show you because of for some reason I wasn't able to manage my screen as well, but certainly the American the American Orthopedic Association and the American Academy have very good guides. I think to have a very good textbook on spine is very useful. My favorite one is a bit out of date now, but that's when I bought it, was John Frymoyer. And some of these people give very good guidance in these psychosocial areas, despite the fact that rather too many of the spine books now only tell us about technique. And that, I think, is a pity, because the real issue here is the treatment of the patient and the assessment of the patient, rather than actually doing something to them. One of the books that I did bring and wanted to try to show you was Ian McNabb's famous book. I don't know whether it does come up here. Yes, Ian McNabb. I've had it on my shelf, and I looked in the cover of it the other day, and I found out that I got this in 1983, and it's a wonderful book, and I think it's still in print. He's now subsequently had a co-author, and I just thought I'd read something to you from the back of his book, and it's on page 231, and it says, in the diagnosis and management of a patient, and remember, we're not managing them, but we're certainly diagnosing them, and we are managing their outcomes. The management of a patient presenting with low back pain, the orthopedic surgeon must play many roles: family practitioner, internist, radiologist, physiotherapist, orthotist, psychiatrist, social worker, and friend. I think to be kind to the patient in a medico-legal report is amazingly productive. It's amazing what people will tell you. And he should really find it necessary to play the role of his chosen avocation, that is, surgeon. And then he said, to those of you that have managed to read this book to its last sentence, may I extend my congratulations and gratitude. So those of you that haven't ever read Ian McNabb's book, it's still incredibly relevant. Some of the pictures in the book are still reproduced to this day in orthopedic texts and neurosurgical texts, and a lot of the wisdom and witticism you would enjoy just as much as you would reading a novel. So I've been lucky enough to have the third place in this seminar. So I hope you've been able to bear with my meanderings, and I've enjoyed very much the other two speakers, and thank you.
Thank you. Thank you, Dr. Dickinson. So we are coming to a conclusion of the discussion this evening. I wanted just to throw one last question to our own Dr. Seckel as he then concludes the session for tonight. And that is just probably 3 brief points, if you have them, Dr. Seckel, around avoiding pitfalls in assessing causation of low back pain.
Sure. Not using the extensive evidence provided in the documentation, for example, in a motor vehicle accident, looking at the police report, the ambulance report, quoting it, understanding exactly what had happened there. Many doctors don't refer to actual factual information, which is not medical factual information, but information that we can use to make our medical decisions. It's totally ignored very often, and it helps to either confirm or refute, because that's our role, to whichever way it goes, to confirm or refute whatever the claimant says. So not using the extensive evidence, including the evidence about how the accident had occurred, which has been discussed earlier as well. Not forensically asking or not forensically assessing the information from the claimant, rather than just writing it down instead of absorbing whether that is realistic or not. And other presenters have talked about that today. not using our evidence-based knowledge of the epidemiological research, and that is very often ignored, but of course we've now discussed that at great length today by the other panelists. Providing real issues are providing equivocating opinions throughout the report. Yes, no, yes, no, yes, no, without actually coming to a specific conclusion. The readers become very frustrated with that sort of a report. Or providing an uncertain opinion rather than at least a balance of probabilities. We've got to come down on one side or the other, even if we have to imply that, look, we can't be absolutely certain, but it's more likely this than that. That's a worse result, a worse outcome, but being able to provide a certain decision. And usually if we use the information as discussed by the other panelists, we can usually come to a clear determination on causation of low back pain. And the last thing I'll mention is having internal inconsistencies in the report. And this is a real bugbear that our referrers commonly complain about, that the report does provide a definite final opinion, but all the evidence in the body of the report indicates X, and yet the final opinion is non-X. So there are many issues that all of us probably have been at fault of doing from time to time that we really need to keep in our minds. So
Thank you.
That's the end, I think, of our presentations. We've had further things that we want to discuss, but we've run out of time. So many IME consultants find it very difficult to distinguish between potential causes for claimed chronic low back pain. Nevertheless, today our panelists have provided substantial practical advice on how to collect and record a wealth of information and evidence, both research evidence and also evidence in regard to this specific claimant's details, that can enable us to reach a clear, decisive determination regarding causation in chronic low back pain, rather than just giving a waffly opinion based on no reason other than that it sounds good. This webinar, by the way, is being recorded and will be available free in the next few days on the websites that, just on our website, that is the Australian Medico-Legal College website, but also on the MEDirect website. I think, Sue, you'll have it on your website as well available. So anybody can download this, the video from today's webinar for your own free use. Just so for those of you who don't know, the Australian Medico-Legal College is a not-for-profit educational college. It's not an agency of any sort. We're doctors working from all over the place, and we're Australia-wide. And we have a training syllabus, including videos like the one that's being produced today. And we have trainee fellows, and we welcome your inquiries if anybody would wish to try to participate and become a fellow in our college. So on behalf of the Australian Medico-Legal College, of course, and the many members of the other medical colleges who joined us tonight and who fortunately distributed the information about tonight, I'd like to thank all the panelists, Vinnie Karana, Ian Harris and Ian Dickinson, immensely for your time and effort and perceptive insights into this complex area of IME work that we've discussed tonight. I'd also like to thank Sue Larson and MEDirect for your extraordinary time and energy in facilitating tonight's webinar, including everything that you did in preparation and using your skills in the way that you can as a practice management system to support doctors in their medico-legal practices. And most importantly, of course, you, the audience, I'd love to thank you for your attendance tonight. I think it's been a very interesting, really very interesting presentation. So good night, everybody, and thank you, everybody.
Oh, a couple of last things, Richard. Save the date.
Oh, yes, thank you. Yes. Save the date. Oh, thank you for reminding me. Save the date. On June the 5th, we're going to have another one of these webinars, again, a free webinar. The topic is Return to Work with Chronic Pain, Medico-Legal Perspectives. And it's going to be presented by Professor Michael Bagg, who at one stage was president, I think, of the Australian
Specialist Pain Medicine Physician College.
It should be a very interesting perspective, because it is directed specifically, again, as tonight was, on the medico-legal perspectives of returning to work with chronic pain. very interesting topic. He's presented it internationally, and I understand it's going to be very, very interesting. Now, there was something, oh yes, one last thing I would like to mention is that our college, Australian Medico-Legal College, jointly with the AOA, the Medico-Legal Division of the Australian Orthopaedic Association, is putting on, as we have every other year for the past many years, putting on an annual seminar. This year it'll be on Hamilton Island, between the 12th and 14th of September. So we would love as many people to join as possible. You clearly don't have to be a fellow of any of those colleges to be able to join this webinar, and you can find out about that by contacting Australian Medico-Legal College on the email address that's there, or via the AOA, Australian Orthopaedic Association. So once again, thank you everybody for attending, and very much so to the panelists and to Sue. Thank you and good night.
Thank you very much. Thank you.